Is she ready? Okay. Okay. Let me just get it on live here.
Michelle, you're recording this?
Yeah.
Okay.
Your face looks good, Jen.
Oh, thanks. I was looking at your bookshelves. I was triple checking. They look good. Remember, because as you just said it, I was like, oh, I'm going to check.
Yeah.
What's behind me?
Just some dilators.
Okay.
Yeah, I know.
Hey guys, we're going live here.
Okay. Thank you, Michelle.
Clean it up, Jen.
Yeah.
Oh, put the wine down, Erin.
Hey, good evening. This is Amy Perlman. I'm a urologist and men's health specialist. Michelle?
And Michelle Perlman, gastroenterologist and physician nutrition specialist. Amy, what do we have going on tonight?
You know, my sister and I are specialists in a very nuanced field of medicine, and we see patients with and without cancer and deal with their quality. But we've never truly been patients in the healthcare system. And Erin and Jen are going to talk to the group tonight about their experiences as patients and this incredible thing that they've done to help advocate for others so that they have better experiences going through the system than those that they had themselves. They have really powerful stories. Every time I hear each of their stories, I learn something new about ways that we as providers can better communicate with our patients and our family members about these things in a more sensitive topic. You've heard me before about how we make every conversation a vanilla conversation. And I learned that from Erin Sullivan, and her, what she says is sexual health concerns in any sort of conversation can be vanilla. You just have to address it appropriately. So tonight, as with many of our talks, is making sensitive topics so vanilla that you can't offend anyone. Erin, talk to us about your story.
Hello, I'm Erin Sullivan Wagner, and in 2008, I was diagnosed with anal cancer, and I had never, of course, the devastation of a cancer diagnosis is, as every patient knows, it is life-altering. So at that point, you really just care about your surviving the cancer, and so do your physicians, and so do your care team. And at the end of that experience, my treatment, I was told I would have no sexual health issues, but as a result of the treatment, it was really as a result of the radiation treatment, I did have sexual health issues to the point that I was unable to have intercourse again. And at the time, I didn't understand why. I was told I would have no issues, went back to my provider and asked questions about it, and they tried every treatment they could. However, it wasn't their first concern. It wasn't really even on the list of concerns. And I realized after I had finished my treatment, I started to life coach other patients, but not about sexual health. It was really about the emotional challenges patients go through that cancer journey. And in my coaching, I realized that almost unanimously, cancer patients have sexual health issues after their treatment. When I would ask, because of that, I started to become more of an advocate for not only patients, but providers on figuring out how to really bridge that communication gap between patients and the providers on addressing sexual health in cancer care. It's a concern for patients when they go back to that normal life that they're looking for. And at the time of a diagnosis, it's just not on anybody's mind. As a result of my treatment, my sexual health issues really did cause eventually a gradual erosion of everything fundamental in my marriage. And over a period of years, it gradually just eroded to a point where we separated. That's true for so many people. If it isn't even that they separate but cohabitate. People really do need to be able to have the connection that they found with each other after this cancer diagnosis and after their treatment. And so often Sexual health is a component that's important to address, but really it ends up being so instrumental in having a domino effect. If I don't have sexual health in my life, but it's important for the connection I have with someone I love, then every other area of our connection can be eroded, which is exactly what happened with me. So I advocate for patients and also for providers on learning how to address sexual health so that they aren't awkward. It's really just a simple message to their patients, really holding a space available for their patients to bring forward questions or concerns. It's really giving them the permission to do that at any time during their treatment so that the quality of life just isn't impacted.
So Erin, let me ask you a question. How far into your journey, as far as like at the time of diagnosis and treatment, do you remember when it actually started to come up in the conversation?
So when I was diagnosed in January, and I remember hearing before started treatment that we really don't expect you'll have any sexual health issues. It was anal cancer, so I didn't really understand that, why I would have sexual health issues, but they said you're not going to have internal radiation, Rod, so we don't expect you to have issues. So when I did have such severe issues, I really believed that, well, my doctor just got it wrong. So I need to make sure that he understands that, oh, wow, you got it so wrong. He'll want to know that he got it so wrong. So I went back and talked to the radiation and the medical oncologist and just let everybody know, you guys got this so wrong. And they said, we really haven't had that many anal cancer patients. And I did push back on that because it really doesn't have to do with the type of cancer. It had to do with the type of treatment.
Yeah.
And how do you know you haven't had issues? You aren't asking, so they aren't telling, because we are guided by what you think is important.
Yeah.
It isn't the patient responsibility to figure out how to bring this topic up. It really belongs to the provider.
Mm-hmm. Yeah, and even if people don't have anal radiation, there's plenty of people that get pelvic radiation, and that causes a lot of scar tissue as well. That can cause a lot of pelvic floor issues and pelvic pain issues that can definitely worsen with intercourse. So yeah, I mean, I totally agree with you that it may not be common to them, but that's just because they may not have asked the questions.
Erin,
Correct.
talk to me about some advice that you can give patients on what questions should they be asking? Because you had said, well, are you sexually active? For example, what does that even mean? So what are the questions that patients should be asking, and tips on how they should be asking those questions and when they should be asking those questions?
Mm-hmm. That's a real question that you're asking. It's pretty broad. It's so important, though, that as providers, that we don't assume that we know what's important to our patients in terms of quality of life. And of course, everybody wants their cancer cured, but there are other things that are important to them. So that kind of leaving assumptions out, I think, is really important. But as a patient, patients really, I think it is their responsibility to do the research of, here's the treatment I'm going to have. It's easy for us now. It's all at our fingertips. We can do the research to figure out how is this treatment going to impact not only my functioning as a person, but on quality of life issues. So what about this treatment? What's this going to do to me afterwards? And with that, armed with that information, be able to very respectfully let your care team know. And I don't think it always is the physician. On a care team, when someone has cancer, people are all around you because there are so many people that are part of your care team, and it belongs there. And it's I know that I'm focused on sexual health because I think it's a voice that is needed because so few are voicing about it. But there are so many issues that go to quality of life. And this is an important self-advocacy point for patients, that understanding what's important to you and how your treatment may actually impact your quality of life is important to be armed with when you bring up to your care provider that here is my expectation after I'm done with treatment. Is that unreasonable? How will this treatment really impact my relationship with my husband. Right now, my relationship with my husband is we have intercourse. Will that be impacted? Is there anything I can do now before treatment to preserve that? Are there options of treatment options possibly that would be better for me, knowing that in the end, that's important to me?
Yeah.
Because, you know, for women, I think we all as a society understand why men want their sexual health preserved. Amy, you speak to prostate cancer patients before treatment about this. If someone has breast cancer or anal cancer or cervical cancer, no one's coming to that patient and saying, you know, you've got some options here. You want to watch and wait. You want to, what would you like to do for your treatment? Nobody does that because female sexual health isn't even concerned in terms of preservation. That paradigm is shifting, and so is the paradigm of the patient-provider relationship and self-advocacy and shared decision-making. So I think it's important for patients to know that they are empowered to have a provider, that those questions of how will this impact me? And if your provider doesn't know, they can find out. That's not difficult for the provider to find out. Patients need to know that what's important to them will be important to their provider. So asking those questions in pretty, you know, Amy brought up a vanilla way. That's pretty vanilla. This is my expectation. How will this impact me after my treatment, during or after my treatment?
Yeah. And I think also maybe, and as hard as it may seem, to not maybe use the word sexual health, because that definition is so different for so many people. And, you know, you're not going to offend the provider if you say, I have sex with my husband. Am I going to have sex after I have treatment? And
well, but Michelle, even more than that, I have vaginal intercourse with my husband. I have anal intercourse with my partner. I was diagnosed with head and neck cancer. I have oral sex. Will that be impacted?
Yeah. Yeah. So I think, as you know, one of the ways to kind of open up that conversation is instead of using more general terms like health or function dysfunction, and actually like expressing what type of action are we talking about, because everyone's definition is so incredibly different.
It is. And I think I say that though, Michelle, because I think it's easy for a patient.
Yeah.
If I have to be the one bringing this up, if I'm a patient, I need some leeway here. I need to not have to say I want to have oral sex, because that's going to be too hard for me in the 7 minutes I have that provider to use the word oral sex. You know, I'm not going to be able to do it. But I might be able to say, how is my vaginal health going to be impacted, and how will that then impact my relationship with my partner? That might be easier, just keeping those terms pretty non-offensive or non-awkward.
No, I mean, it's hard. But yeah, I mean, that's the thing, is as hard as it is for the patient, you know, the provider is a human as well. And it's just as hard for us, you know, despite having 4, 8, 10 years of training, this is not part of our routine training. So it's hard for both parties involved.
What I've learned recently from having more discussions with my colleagues who have a particular interest in treating transgender is, before even doing a physical exam on someone who is transgender, when that's a very vulnerable situation, is when you're sitting down with the person and you say, okay, before we do the physical exam, I want you to tell me how you call your genital parts. Do you say vagina, penis, dick, cock? I mean, we see those as being bad words, but everyone uses different words for those parts, and then mirroring those words. Okay, so I'm going to examine your penis or your front hole right now, you know, and it makes it more comfortable. But maybe that's what the conversation needs to look like is, okay, we're going to talk about everything that you can expect after cancer treatment. How do you define sexual activity? Or and then providing examples. Do you define it as oral sex, vaginal sex, anal penetration, whatever? Erin, thank you very much for sharing.
Yeah, the only one other thing I wanted to say real quick, and I'm sorry that I'm talking too much. But so I just think it's important for providers to know that we understand as patients that this is all awkward. we're awkward talking about it. We know it's awkward for you. We know we're all a little embarrassed about having to talk about it, but we also know that you not talking about it, or you as a provider looking a little surprised that I care about my sexual health when I'm about to enter cancer treatments, that's awkward.
Yeah.
So I can smell awkward before you even realize you're awkward. And I will shut down.
Yeah.
And I will give you nothing. I won't necessarily do so well in being compliant probably either. There's a lot that's impacted when that communication gap isn't bridged.
And Michelle, something that you had mentioned in one of our previous conversations is you see patients after cancer who gain weight, but are too embarrassed to mention, you know, oh, you treated my cancer, thank you so much, to the medical oncologist. But now I can't fit, you know, and I think it's a similar conversation with weight, right?
Yeah, because when people are going through cancer, they get, you know, many times if they're getting chemo, they're very nauseous. And so they're told by everyone, just eat anything, you know, all you need are the calories. And I don't believe in that, because if you were to get a ton of fast food or eat a bunch of pizza, you may get the calories in, but now you're going to feel worse. You're going to throw up. So whatever you just ate is not really helping. Plus you may take in a lot of calories, but it's not actually giving you the nutrients that you need. So I'm not a proponent of just getting in whatever you can because you have cancer. I think there are ways to do it in a systematic way where, let's say you can't tolerate a ton of food, you take in small volumes of calorie dense, nutrient dense foods like avocado or plain nut butters, plain Greek yogurt that are full in fat. There are ways to get down food. And so if for several months during their cancer treatment, you know, patients are taught just eat whatever you can, then as soon as they're done with that treatment, they still continue doing that. So it's not only the cancer treatment and the medications that altered their metabolism, it was also the approach from the team, from their providers, that basically said, just eat whatever you want to get through this. And so it's really kind of a whole mind shift change. And I think we have to definitely approach it differently if we want to improve these outcomes.
Yeah. And Jen Lee, so Jen is a psychologist and is a cancer survivor herself and advocates for, as what she calls, she advocates for people on the margins, which I think is an incredibly beautiful thing that she does. You walk us through your story and some of the work that you're doing today, including some of the work you're doing with nutrition counseling.
Sure, absolutely. So I'm a almost 14-year survivor, in 3 days, 14-year survivor of cervical cancer. And I think I was 28, 29 when I was diagnosed. It was right around the year, right around my birthday. So I can't remember if I was 28 or 29. But basically I was a young person with cancer. It turns out I wasn't that uncommon. However, yet I didn't get any of the resources. I didn't have any of the talks about what to expect side effect wise, long-term in terms of quality of life and daily function. And so I didn't really know what to expect. I didn't know what to ask. And so I did chemo, I did radiation, I did radical hysterectomy with lymph node dissection. And so I had a pretty aggressive year treating my cancer. And I think one of the things that surprised me is that I was so focused that I didn't pay attention to any of the emotional or social health. And I fell apart after a while. I didn't really talk about what I was going through. Half of the people in my life didn't even know that I had cancer because, you know, I was this successful health professional, you know, with a doctorate in health studies. So I thought it was a weakness to suggest that I myself was affected by a disease that I was supposed to be an expert on, that I should have known better than to end up with this disease. And I think part of the certain cancers, and so we do indeed give less support societally and even in clinics to certain cancers, and give more support to other cancers. And that creates a barrier also because people don't feel like they can ask unless they have some of the cancers that get more positive attention in society. And so I always love what Erin has to say because everything she says, I'm like, yes, me too, me too. I didn't know what questions to ask. I had no idea what long-term side effects. desperate to save my fertility. And I was willing to do anything I had to save my fertility, because I was 28 without kids, and all I ever wanted to be was a mother. And I wanted a baby in my belly. That was a long-term dream. I thought that was the most amazing look and feel that I just could not wait to have. And so even with that, there was very little support or suggestions of what I could do. Fortunately, nowadays, we do have a lot more options for oncofertility, is what we call it, or their fertility. So today the world is a lot better, thankfully. And my doctor's amazing. He's told me since, like, I wish I had these options for you, because I would have loved to use them. And so fertility is a big one that I've focused a lot on with advocacy. And then, of course, like what we talked about before with like physical health, sexual health, all of that. Like I said, I didn't know what to ask. So I didn't know I was supposed to ask anything unless the care provider talked to me about it. A big part of self-advocacy for me is that different providers have different opinions on what's most important. So if you have medical oncologists, radiation oncologists, surgical oncologists, and your GP, you have 4 different people who think that they might have the best answer to your symptoms, or the best conversation to have about what treatment you should get. So there is a little bit of, I guess I'm going to call it infighting. Just, that's kind of how we are. That's why we pick the fields we do, because we think it's pretty darn important. And so, like, in terms of what one provider is telling the other, or what one provider is telling a patient versus what another one is. And so I would say that, again, nutrition's a big one too, that in my work with patients, I do a lot of counseling and advocacy and navigation, just helping people navigate the system, because we just don't have the resources to do that in a lot of healthcare facilities. And so one of the things that comes up a lot is nutrition, that people are finally getting the word that nutrition matters for cancer. And so that's a question I get a lot. And in fact, there is so much empirical evidence for many different cancer types about what to eat, or what things to be concerned about, like what we were talking about a minute ago. Even the types of foods you eat during your treatments, some foods are hormone receptive. And so you could be eating foods that are making your disease worse, or your treatments can't have the same effect because of what you're eating. Or even the fatigue, if certain foods make you more tired. And so people will think it's the chemo that's making them more tired, or the radiation, but it could actually be the foods, very much so. So those are things that, like Erin said, we have to be able to get the information ourselves to advocate, because most of the world doesn't know how to find what information is reliable and what's not. And so those are some of the dangers that we end up seeing, is that if we don't offer the verbal supports and kind of hit people over the head with, if you have questions about anything, contact me, or here's the person to talk to, because people just go to the internet, and that's pretty dangerous, because many people won't go to the next step of their treatment because they're afraid of what's going to happen. That happens especially here, and we just don't go to the next medical test because it was so painful, or the side effects were so bad, or they were so afraid of what could have happened, that they just never show up, and they stay home and, in some cases perish. That's a big problem in rural Iowa, especially. So with advocacy, I'm a very big proponent of speaking for ourselves, but most people don't know how to do it, and they don't know how to get the right information, and people want to be nice and polite. I always tell people, if your care provider is not open and receptive to you being a part of the decision-making provider for you. And in fact, University of Iowa Hospitals administrators, I'm on a lot of patient advisory boards where we advise the hospital on best practices and do our best to make sure all patients come to University of Iowa hospitals, because we do have top of the line care. We have UHC tells me, if providers aren't having that conversation with, look, this is a team approach, that's not really something they want happening at their hospital. They want all providers to be having a team approach. But the gap is, how do we help people help themselves? Because a lot won't.
Yeah, and I think a lot of providers, let's say, may not know much about nutrition. And I think that is totally fine because it's complicated. But I think it's about at least having that conversation and then saying, okay, I totally understand that that's a very important concern for you. Let me direct you to X, Y, and Z where they can actually help address those concerns. So it's not that your primary medical oncologist has to have all the answers, but they should at least be able to direct you in how to get those answers.
Yeah. And Erin, you have, you talk about creating a referral roadmap. And that's been really critical in my practice, is understanding, I feel like I'm humble enough in my practice to know what my specialty area is. And I know a lot about a little. And there are other areas that I know nothing about or very little, but I know who to send my patients to. So all these topics are really important. I apologize. I don't know much. I have a really good nutritionist that can talk to you about all the nuances, right? And so making a referral early and to the appropriate person.
The referral roadmap, now that you've brought that up, that's also one of the things that really is involved with that communication gap. As a provider, you're not asking your patient questions that you don't know how to help them with whatever answer they give you, So one of the things that would help providers is having a roadmap of what are the common issues that my patient might have from this that they're going to face, whether it be chemo, radiation, or surgery, whatever it is. What is typical? What will be common for them? And then based on all of those issues they're going to have, maybe I need to find out where's the physical therapist in this hospital or in our network. First, in the internal network is important so that you're keeping the business within the organization. But, Amy, I've watched you do a wonderful job with just reaching out and saying, hey, here's what I do. What type of patients do you want? So that I can make sure I know where to send my patients. It's so critical. As a patient, when I wasn't referred out when I should have been, it was the difference of me being able to have intercourse again. It made the difference. I didn't win that battle because I wasn't referred out in a timely manner. It is as important as bringing up the topic of sexual health for your patient, is knowing when your patient needs to be referred out and who to refer your patient to. If as a patient, I had been told you really need to see someone, told whom, depending on how much I would self-advocate, how much I would do the work, I may or may not figure out who to go see. As Jen was saying, especially those patients in the margins.
Yeah.
And I was going to say too that when Erin, you were talking about some of the stuff you were talking about, reminded me that some of us don't want to answer these questions in front of family and friends. I have a friend who's concerned about, death and dying issues. She doesn't want to have those conversations in front of her partner, or I don't want to be asked questions about sexual health in front of my partner. Maybe it's a difficult conversation, or, and so sometimes I think it's important for us to have those conversations one-on-one, because I think we're going to be more honest, and to have it from a neutral person, those conversations. Sometimes we're afraid of our cancer provider. I mean, I put mine on a pedestal. He is just amazing, and he is that remarkable, but there's some things like, I don't want to sound silly or dumb, or, like, what, he's going to wonder, why do I care about this? But I think part of it's that sometimes it's best to not have it come from our main provider. At University of Iowa, we have a lot of amazing NP, nurse practitioners, and PAs that are remarkable, and they're not the oncologists. And so it's so much easier to talk to them because we don't have the same perception of them being kind of this scary person who saved our life. It's more of a one-on-one relationship that we build with some of those other.
I'm chomping at the bit to talk to you about this. I do understand what you're saying about your provider, and I think most of us do have that kind of God complex with our providers who care. I think it's understandable, and that's just honest. I think your provider, though, has the responsibility, whether it's the doctor or the care team, and I'm not saying that the physicians have to be the ones that bring it up, but it is the responsibility of that care team to normalize it for you. So I know we think they're God. I know we really do idolize, and we would think, how petty. I'm going to bring up my sexual health to this physician who's curing cancer, really has more important things to do. When really care team, I'm not saying only specifically the physician, sometimes I just want the physician to champion the approach.
Yeah.
But if that care team brings up to me that we know your sexual health may be important to you at some time again, it may not be important right now, we get it, that's not the first thing on your mind, or maybe the second or third, but eventually we do think life is long and you might care about it again, so we want you to know it's important to us too, because it's a quality of life issue. We have resources and we'll be able to refer you when you need it. I could say that in front of your 5-year-old. I can say that because that's vanilla. There's nothing offensive about me letting you know as a patient that I'm here to help if you want it. I'm not saying you should need it, but if you ever do, we know it's important to people. It may be important to you and we're here to help. Such an easy 30-second message anybody can give, should give. I think it's their responsibility to give.
Amy,
Erin,
that's where
if
you
I had
stole
a
your
mic
line
drop
from.
right now, I would literally drop the mic.
Amy, that's where you stole your line from. I heard that.
I
Erin
know,
always does
I
that.
know.
From Erin.
I give Erin credit all the time, but seriously, I think Erin just kind of solidified that is a 30-second script. That is a 30-second message that the medical assistant, the nurse, the PA, the NP,
Anybody.
the physician, the psychologist, the psychiatrist, a family member should be able to have with everybody, you know,
And that person that has it actually is who Jen's talking about. Jen might want to have that conversation, not necessarily with her oncologist. She wants a one-on-one conversation with maybe somebody she's connected at a deeper, at a deeper level, possibly somebody she spent more than that 7-minute call in the office. You know what I mean? The nursing oftentimes, but social work, I mean, there's a lot of people that could have this. But it truly is a 30-second message, which really all I'm doing as a provider for Jen is just giving her the permission that if she's got an issue, we think that's normal. We think that belongs here in our conversation. We think that's a medical issue. If we cause your issue with our treatment, we think that's an issue that belongs here to help you solve it.
Well, and I think we have to make, I personally think that we have to make quality of life almost one of, because we don't talk about quality of life hardly at all. I mean, we do, but we don't. So, right, because quality of life becomes like this catchphrase that everyone throws around, but never really means anything. But it does mean something. And all of the, especially in cancer research, it's often quality of life that predicts who has recurrence and who doesn't and who lives the longest. There's so much research that quality of life can be a stronger predictor of cancer outcomes than even disease, original diagnosis information. Identify their quality of life. That is often leading to a longer, a healthier life. And there's so much data on there on long-term outcomes. If we look at quality of life, that quality of life is a stronger predictor than a lot of disease-specific things. So we really have to help. We have to tell people we as patients, we have to tell what our quality of life is. What does that mean to us? Every time we come in, that should be something we measure, just like what we put in, we measure pain, we measure fatigue, we measure all this stuff. We should be measuring quality of life. And the thing that brought me into sexual health research and work is, for most people, sexual health is a big component of that. And yet it's the most neglected one. And so, and that's why I've started to measure sexual health and quality of life and other diseases that I work with as a researcher, because it is like often the missing ingredient that we don't pay attention to as patients or providers that could change people's entire life if we can help improve this. For a lot of people I work with, they would rather than, for some of them, they would rather focus on quality of life than specific things about their treatment, that they just want to know, how will this impact my quality of life? That it's often the number one thing that determines what treatment they want to do. So I think quality of life, we have to make it our number one. And to be honest, as a patient, if I don't have good quality of life, I'm pretty miserable anyways, and so I kind of think we need to start making more of a push to make that a top assessment that we do.
Yeah, and I think it should be during the initial time that you are.
It wasn't a choice, right?
Go ahead.
No, I feel sometimes like, we have to talk about quality of life as opposed to treatment. It just doesn't need to be a choice. It needs to be taken into consideration that as soon as I survive this cancer, the rest of my life, I got to figure this out.
Yeah.
And sexual health, I know, ends up being a bit of a catchphrase too. I really think what we're talking about here is emotional intimacy. I really think that we're just tied with others and ourselves as what's important, and sexual health just becomes such a large component of that very often. But there are a lot of people that need good vaginal health. So for females, vaginal health, not for sexual reasons. They might not be partnered, but it will matter to their emotional intimacy.
Yeah. And I think having that conversation at the time of diagnosis. So I see this all the time in regards to nutrition, where I get referrals for patients who have lost 30 pounds because they can't eat anything and they've had radiation and chemo and now they're on their third cycle and they're so malnourished now that I'm trying to catch them up when I'm already 10 steps behind the ball. So I think at the time of diagnosis, that's where you ask people, when you're ready to talk about more sensitive issues, who do you want in the room with you? Like that conversation should come up. So
That's great.
Occurs, you're not in a weird situation. Everyone is on board. It's put in the chart that when we talk about sexual health, this is who the patient wants involved in the conversation, or these are the patient's worries. And when the patient's ready, that's what we're going to talk about. And that should all be documented. Or nutrition, like again, you don't wait until the patient's already gone through chemo radiation. Any patient who has cancer should see a nutritionist. I would argue that any patient that's in the medical system would at least benefit from a one-time visit with someone who can give them nutritional counseling. Particularly with cancer, it's a hypermetabolic state, plus with all the treatments that messes up your microbiome, etc. So it shouldn't even really be a choice. It should be offered unless the patient says, no, I'm not interested. It shouldn't be, oh, we have a resource. You let me know when you're interested in seeing a dietitian. The conversation should be, you have cancer. This affects nutrition. And in order to improve your outcomes, we want to make sure we optimize that as much as possible. So I'm going to set you up to see one of our dietitians, and then you tell me if you're not interested, but I would recommend that you talk to someone about it. And that conversation should have before any treatment conversation or before the treatment starts.
Yeah. And I would actually argue that we have to make nutrition and sexual health part of the standard of care, where it's just brought up automatically as a part of the standard of care, especially with nutrition. Because look at how much we can change people's outcomes if we help them change their nutrition. And so it's almost like insurance providers should require the nutritionist to come in for, any chronic disease practically, because we're saving everyone time and money and suffering by helping people with their nutrition. We were kind of joking about this before we came on live, as it was like in cuisine, our smart ones are healthy foods, or they're like, I had corn and mashed potatoes for dinner. That's healthy, right?
Yeah.
And it's a vegetable.
Yeah, I know.
It's popcorn. I was checking out the other day, and the popcorn is called smart food. So the marketing, they use all these terms, so a consumer may not know any better. The problem is that nutrition's not sexy, right? So pharmaceuticals are sexy, cancer research is sexy, developing the newest chemotherapy that's going to cure your cancer, that's sexy. Talking to someone about eating real food and dumping the junk is not so sexy. And so you have to get buy-in from your healthcare system to support resources that cost money that will end up reaping a lot of reward in the future, but there's a big time gap before you see those outcomes.
Yeah. All right. We're going to wrap up tonight's session. I mean, we have a nutritionist, patient advocate, psychologist, mental health providers. Look how sexy they are. They made this conversation pretty sexy tonight, wouldn't you say? Hey, we appreciate your time. Erin and Jen, thank you so much for sharing your stories.
Thanks for having us
tonight. And we'll have to do this again sometime on a related topic because this was great.
Thanks. Everyone.
Thanks, everyone. Bye.